So this is one of the few slides that has a visual component. Can you hear me? Okay. Who sees, what is the slide? Coral? Anything else?
In the middle, maybe? Yeah, there's the eye. I think it's coming out.
Okay. So this is actually quite poisonous. It's a rockfish, and it lives amongst the corals and is well camouflaged, as you could see from the first one. As a scuba diver, it turns out I'm actually not very good at finding these. My wife is, so I take the pictures and she does the looking. Why does that have anything to do with thromboembolism prophylaxis? It doesn't, but with a topic so dry, you use anything you can. No, the point is that with deep venous thrombosis, if you don't look for it, if you don't specifically go out looking for it, you won't find it, even if it kills your patients. So this is a study done by a guy by the name of Bill Gertz. He's Canadian. He works out of Toronto. At least last time I talked to him, he was in Toronto. And I think he's always going to be a Canadian, but I try not to hold that against him. So he enrolled 350 trauma patients, give or take, and then he followed them up with venograms. And that was really revolutionary at the time. It was done a while ago. I mean, it's not a recent study, but it's probably the best natural history study for deep venous thrombosis that there is. The reason being is the sensitivity of venogram is very high, as opposed to the ultrasound that we typically get. A duplex Doppler interrogation is actually very low, and it's very low in the most critical point, and that is above the inguinal ligament. Anyway, when he looked at trauma patients, and the average ISS of these trauma patients was a little bit above 20, which would correlate to our ICU trauma patient population, what he found was more than half of the patients, if you looked for it, had clot in the deep venous system. And if you were going to say, well, okay, but I don't care about anything below the popliteal vein, which some people want to say, only proximal deep venous thrombosis, it was about 20%. The problem is that the distals turn into proximals. He had no good screening mechanism for pulmonary embolism, and so his incidence of pulmonary embolism was that in the literature, nothing surprising there, of being about 2%, with about 1% of them being fatal. So this one doesn't show up very well. I'll just take 1 second. Oh, I don't know if I can kill the... Can I kill those lights? There we go. Anyway, that's Teddy on the right and the next generation on the left. So there was a guy by the name of William Hewson, and what William Hewson did in the era of the Hunter brothers was he looked at the idea that blood clotted in response to its contact with air. And that makes some sense. If you cut your hand, the blood is exposed to air and you get a blood clot where the cut is, that seems to be a logical argument. And so what he did was he took a bunch of dogs, and the dogs were bled in aliquots successively until the dogs died. So I don't do experiments on dogs. I sleep with them. I mean, not like any, But so what he found was something very remarkable, and as you read his writings, it's just a passing comment, and that is the last blood out is the first blood to clot. The last blood out of the dog was the first blood to clot. And at the time that was revolutionary because that meant it was not contact with air that caused the blood to clot. These dogs are just sitting there wagging their tails, at least at the beginning. There's really no stress on the dog. All that's happening is we're bleeding, taking blood off the dog, and successively it's getting more and deeper into shock. And so something in that milieu of hypovolemic hemorrhagic shock makes the dog hypercoagulable because the last blood out clots first. So you don't even need trauma. You just need hypovolemic hemorrhagic shock, and you're a setup to have clotting. So why does a guy choose to do basic science research on clotting in trauma? I'm a trauma surgeon. That was one reason. The real reason is because as a young faculty member, if there are any here, and you want to rise to the level of full professor with tenure, you have to publish and you have to get funded. And you either have to be the smartest person in the land, and then you can study anything, or you have to pick something so boring that there's no competition. I went with option B. But specifically in trauma, what we study is we study a situation where we have a very high incidence of the disease that I was interested in studying. So that means that I can do studies with relatively smaller numbers than if I were doing, say, medicine admissions and studying the same issue. The second thing is that the patients are typically relatively healthy except for the specific insult that occurs. Now we have our octogenarians that break their hip and then fall, but that's really not the population that has been included in most of the studies that I'm going to present that are my own. And the other thing that's really remarkable is that as opposed to cancer, you can with great precision define the onset of the disease. When did breast cancer start? By the time it's palpable, we are now believing that that breast cancer's been there not for weeks, not for months, but for years, and not for a year, but for years and years and years, okay? So when does the risk for thromboembolism and cancer start? The answer is nobody really knows. So there's the explanation. What's the end point? The end point, ideally with any good study and with any really serious investigation, is something that is easily defined and easily measured. And so ultimately the end point is death. That's a relatively easy to define endpoint, and it's also relatively significant to most individuals. The problem in pulmonary embolism is that we don't really have good screening studies. Frequently we rely on a clinical diagnosis and then that prompts us to go down and get a CT scan. And in fact, this is starting maybe to tip into the other direction, but historically, up until very recently, the vast majority of pulmonary embolisms went undiagnosed, even if they were the primary cause of death. This is from the American Journal of Medicine, where they looked at about 1,500 autopsies, and specifically they looked to see if the patients had pulmonary embolism. What they found was there was a 15% prevalence of pulmonary embolism in patients dying in the hospital, 54 major, 162 minor. And if the pulmonary embolism was the actual cause of death in the pathologist's opinion, as clinicians we got the diagnosis right 30% of the time. If it was coincident, we essentially whiffed. We never got it right. Bigger study later, this is after the acceptance of a fairly landmark study done on the use of heparin to prevent pulmonary embolisms. This is 21,000 autopsies. And here we see a decrease with some prophylactic activity being used, down to about 10% of all comers. But with that, as the incidents seem to go down, our diagnostic acumen seemed to go down as well. So if the PE was the specific cause of death in the opinion of the pathologist, it was on the death certificate or in the medical record somewhere in about 1 out of 5 cases. And if it was a contributing cause, it was there in about 1 out of 10. As we've gotten more and more advanced in our ability to image, whether that's MRI or the light speed CT scanners that you have 128 sensor light speed CT scanners. When I was starting out, we were just getting CT scanners, and they were 2 sensors, and it would take you an hour and a half to get an abdominal CT scan, and the pixel was about 1 inch. And so the ability to diagnose pulmonary embolism on CT scan was laughable. Now, the resolution is so good that the PEs on CT scan are sort of becoming like the incidentalloma. It's like the adrenal mass. What do you do with it if you're getting it for something else and they have a PE and it's not causing them any problems? The next question that I thought was relevant to ask was, if people after injury are having pulmonary embolisms, that's unequivocal, and they're dying of them, that's unequivocal, and that more often than not, if they die of it, we don't even know that they died of that cause, it would be really a good idea to know when the patient really is at greatest risk of dying or of having a pulmonary embolism. And so what I did was I looked at about 100 patients that were diagnosed with pulmonary embolism that was unequivocal. So this was pulmonary embolism diagnosed either by autopsy, and that one's pretty straightforward, by pulmonary angiography, and the only VQ scan that was acceptable for this study was a high probability VQ scan. And in the nuclear medicine world in this era, the percentage of VQ scans that were read out as high probability was about 4.2. So in effect, it never occurred. But when it did occur, when you correlated it with a pulmonary arteriogram, the high probability VQ scan actually was quite accurate. We had 17% mortality. And what I found was quite different than what my mentor had taught me, which was that if you have a pulmonary embolism after injury, within the first, say, 48 hours, it's not a big deal because it's going to break up, it's going to go to the lungs, it breaks up, goes out to the periphery. Originally, heparin was beef lung heparin, that's where we got it from, or porcine lung heparin. It was, the lung is very rich in antithrombotics and fibrinolytics, and so it would go out to the periphery of the lung, be metabolized, and off it went. And my findings were actually quite different. My findings were, first of all, that the idea that you really don't get a pulmonary, the wind, water, wound, walking wonder drugs for your fever, that's in order of when they occur. So if you have a fever on post-op day 1, wind is atelectasis. Water, you get, the drill, but the walking is deep venous thrombosis, pulmonary embolism, and that's not till day 5 or 6. And the theory was it's not till the clot's organized. But in fact, if you looked at the first couple of days, and over a quarter of the patients, about 1/3 of them, had their pulmonary embolism within the first 4 days. And there was a large contingent that had their pulmonary embolism within the first 48 hours, and that group had the highest mortality. And that led me to do some studies in sheep using glass beads to mimic pulmonary embolism, and I floated glass beads in the sheep, and I would get a beaker of these glass beads that I could float up to the lungs, And I'd sit there and I would float a bead and I'd watch, and I'd float another one and I'd watch, and I had the sheep all hooked up and wired, and the whole time the sheep's just looking at me like I'm an idiot and never does anything, does perfectly fine. The sheep's PaO2 never changes. So it made me rethink the whole concept of what a pulmonary embolism is. The thought of it being a mechanical issue that goes into the pulmonary outflow tract and blocks blood flow from getting to the lungs is wrong. What's the primary manifestation of a pulmonary embolism? Let's go with someone way back in the back row. What's the first thing that happens? What drops? Straight back. You're on the hot seat.
Blood pressure?
Okay, blood pressure, if it's a really big one, that would go really fast. That's good. Phone a friend, see if we get another answer. Someone else back there?
Oxygen saturation?
There you go. Yeah, they drop their PaO2 or their hemoglobin oxygen saturation. But if I go in and I go to take out a lung, the first thing I do when I'm going to go do a lobectomy is I ligate the pulmonary artery. Because if I don't, and I ligate the pulmonary vein first, the lung becomes grossly engorged with blood. It starts to look like liver, and I wind up taking out about a third of the patient's blood volume. So I ligate the pulmonary artery. And as soon as I ligate the pulmonary artery, I got to tell anesthesia, because they may have some right heart problems. But what happens to the O2 saturation? All the blood that's coming up through the heart is now not going to the right lung. Let's say I'm taking that one out. It's all going to the left lung. So it's all going to ventilated lung. Nothing happens to the PaO2. It stays normal. So pulmonary embolism is not a mechanical phenomenon. It is an inflammatory phenomenon. And the reason that you become hypoxic is because what goes up into the lungs is not a glass bead. It is an inflammatory mass that causes an inflammatory burst that releases cytokines and causes bronchoconstriction and vasoconstriction, but not in a uniform manner. So now you've got perfused but unventilated alveoli. That's how a pulmonary embolism works. The mechanical component actually has almost nothing to do with it. And the sheep, I think, is probably still grazing right now with all those glass beads. So if the first sign of a disease process that occurs in your patients in a significant number is death, prevention is probably better than treatment. Since the treating death, that one happened about 2,000 years ago, it's been done. I don't think it's been replicated in any other centers. So we've got pharmacologic prophylaxis, we've got the pneumatic, the squeezers, yeah, that was a joke, and then mechanical, and specifically the cable filters. So what are our options in terms of pharmacology? And I'll really focus primarily on this first group. We have just the old unfractionated heparin that is as cheap as dirt. We have the low molecular weight heparins, which are now pretty close to being as cheap as dirt. And then we have another drug that goes by the trade name of Arixtra and the generic name of fondaparinol, and I think all those names are ridiculously complex because what it is a 5-sugar moiety, that's it, there's no more to it, so why not just call it pentasaccharide, that's what it is. And how the different drugs work in that group, you notice I listed them all under their antithrombin potentiators. So these drugs, heparin, low molecular weight heparin, or whatever you want to call it, Arixtra, have no anticoagulant properties. Heparin is not an anticoagulant. Your pharmacology teacher, if they told you that, was lying to you. It is a potentiator of an endogenous anticoagulant, and that endogenous anticoagulant is antithrombin. There is no antithrombin 1, there is no antithrombin 3, nor is there an antithrombin 4, so there's no 1, no 2, no 4. So in all of my writings, I have declined to call it antithrombin 3, which seems to be the popular nomenclature. But since there's no 1, 2, or 4, that's kind of like being called Tom Jones the Fourth, and your dad's name is Frank. So how do they work? Basically, their potency is dependent on how long the chain is that's attached to that 5-sugar moiety. The pentasaccharide, that 5-sugar moiety, that's the one, those 5 sugars are the ones that bind antithrombin and activate it. Okay, so it's the 5 sugars, that's it. That's what goes in there and binds the antithrombin. So if you go with a really, really long tail, or a combination of a lot of long tails and some middle length tails and some short tails, that's unfractionated heparin. It's got a whole bunch of stuff in it. Low molecular weight heparin has just a short tail. And then pentasaccharide has no tail. And as you go shorter, you decrease the amount of direct antithrombin activity, or not direct, but indirect antithrombin activity, and you increase the percentage of 10A activity. Originally, the thought was the more 10A activity it had, anti-10A activity, the less you were likely to bleed. Turns out, not true. Just flat out makes not one whit of difference. But the key point, and this is one of the objectives, how do they all work? They work by potentiating a molecule that you all have endogenously. There's a nice cohort of patients in Japan that has the genetic deficiency of antithrombin that has been studied quite extensively. And interestingly, if you have less than 80% of your normal antithrombin activity, you will spontaneously form deep venous thrombosis. Contrast that with hemophilia. In hemophilia, you only need 5% of factor VIII, and you will form normal clotting. You will be able to walk around normally and not bleed from your eyes like our Ebola friends that we're now going to, I guess we're all going to have Ebola by next week, so that will be a common phenomenon. But basically, we're set up to prevent bleeding, but we're really not set up to prevent clotting. This is the only study, to my knowledge, and I've looked at the literature fairly extensively, that really demonstrates a survival advantage with anything related to pulmonary embolism. So this is patients undergoing hip surgery. It's elective hip surgery. They either got placebo or they got low dose heparin, and this was the 5,000 sub-Q TID, and the first dose was administered preoperatively. The first dose was administered preoperatively. So can I generalize that to the trauma world? No, because I can't give them a dose before they crash. Put it in the airbag? That might, I mean, it might work, but probably it's not soon enough. So this is hip surgery, preoperatively dosed with unfractionated heparin. Then they used what turns out to be an excessively sensitive method for detecting DVTs. And they followed their autopsy, and they did a pretty good job of getting autopsies, relatively speaking. What they found was they had a 4% death rate in these patients undergoing hip surgery. PE was the cause in 9% of those, and fatal PE occurred in 16% of placebo patients and 0% of the patients that got unfractionated heparin. Hemorrhage was no different between the two groups. This is it. That's it. That's the end of the level 1 data in terms of clinical trial with the endpoint of death and thromboembolism prophylaxis. There ain't nothing else. So everything else is a Me Too study. And what they do, what I do, what's been done, because that was essentially 5,000 patients to get that done, is deep venous thrombosis is used as a surrogate endpoint for pulmonary embolism. And the idea is if you don't have a deep venous thrombosis, you can't have a pulmonary embolism. This is looking at colorectal surgery. Basically, it's looking at unfractionated heparin versus low molecular weight heparin. It's just basically, it comes to the conclusion that low molecular weight heparin is more potent than unfractionated heparin. Venogram on days 5 to 9, and what they found was that in this group, there was actually no difference in terms of DVTs, no difference in terms of proximal DVTs, if, again, that seems to make a difference for you. No difference in bleeding that required return to surgery or killed the patient, but in minor bleeding there was a difference. Another one looking, this is in trauma patients, and here this is the 5,000 units I actually think this one is 7,500 units sub-Q TID because they're trauma patients, and the thought is, well, they're going to need more. And about 150 patients, half going with low-dose heparin under the standard protocol, the other half getting enoxaparin. Deep venous thrombosis diagnosed by venogram, 45% occurred in the low-dose heparin group, 30% in low molecular weight heparin. Proximal DVT was, both of these were statistically significant, was higher in the low-dose heparin. Now, if you, this is the same guy, Bill did this, and these are Canadians, which is how you can do a placebo-controlled study because they're only Canadians. So, you know, if you look at his placebo, where he gave them no prophylaxis whatsoever, and this is after the CACAR study that demonstrated that heparin reduces death. So he said, I don't know how he got it through the IRB, but my conclusion, it must just be that there's enough Canadians that they didn't worry about it. So if you take his placebo observational study and you pair it with the low-dose heparin arm of his low-dose heparin versus low molecular weight heparin, what you find is there's no difference in the rate of deep venous thrombosis, and obviously no difference in the rate of pulmonary embolism. So in trauma, giving 5,000 or 7,500 of unfractionated heparin TID is completely ineffective. It does not work. It doesn't do any good. You might as well squirt it on the wall. It will work just as well, and the patient won't be mad at you for stabbing them. So this is just a cartoon illustration of what we're talking about. So if you're talking about unfractionated heparin, it's all of this stuff down to your 5 sugars. Low molecular weight heparin, this part's gone, and you've just got this. And if you're talking about fondaparinol, Arixtra / just pentasaccharide, it's that. And then this is a cartoon that illustrates that what happens is, oops, the pentasaccharide binds the antithrombin. If there's a nice long tail, it wraps around thrombin. If there's not a nice long tail, that's cut off, it tends to do 10A, or it may wind up doing 9A. It actually inhibits 10A, 12A, 10A, 9A, 2A. There's a number of different factors that it inhibits. But anyway, they all work through the mediator of antithrombin, which caused me to say, well, gosh, if the heparin doesn't have any utility outside the presence of antithrombin, and if you are below 80% normal human plasma activity of antithrombin, you will spontaneously start forming clots. I wonder what happens to antithrombin after critical injury. So I enrolled about 160 patients. These were consecutive patients, and the entry criteria was they had to go to our main resuscitation room, which was where in the ISS scoring, in terms of technically how badly hurt they were, in that rubric, the not hurt, winged, or bad hurt, they were bad hurt. That was also a joke. So the average ISS for this population was about 25. And the second criterion was that after they were in the resuscitation room, they had to somehow wind up in an ICU. So I specifically wanted to target, I wanted to look at the patients who were the sickest. And what I found was that if I looked at all the patients, oops, wrong button, the buttons are too close for my fat fingers. What happened was antithrombin levels drop after injury, and the first sample was drawn with that first blood draw when they hit the ER. How did I do it? We would have our tubes all with a rubber band around them and use a syringe, poke the syringe, get the blood, and then spike each of the tubes. Well, I just managed to get my tube stuck in with the rest, so they didn't even know they were putting it in a study tube. And so I got a very high rate of collection, and then the informed consent was a delayed informed consent. So we actually had to go to the patient the next day or whenever they were able to talk to us, or when their family was able to talk to us and say, may we include your data in this study? So our first sample was done pretty much right after injury. We had relatively short transit times, and what we found was initially there's this little window where it's not depleted, but then it depletes quite quickly. These are the trauma patients that didn't go on to develop deep venous thrombosis based on screening at hospital day number 7. And these are the patients that did go on to develop deep venous thrombosis at hospital day 7. And the method of thromboembolism prophylaxis we used during the study was thigh-high sequential compression device stockings. Because if we'd used heparin, that would have boogered the data because it would have depleted the antithrombin to a degree. And so what you see is that the patients that ultimately are going to wind up with a deep venous thrombosis actually have less of the antithrombin. That's why 5,000, 7,500 sub-Q TID doesn't work, because it doesn't have the molecule that it needs to bind to in order to have its activity. Why do we have PEs early? We'll look at where the nadir is in our own endogenous protective mechanisms against pulmonary embolism. PEs were really no different than deep venous thrombosis, which is the argument for using DVTs as a surrogate endpoint for pulmonary embolism. This is looking at pentasaccharide in hip fracture patients. They took about 1,700 patients and divided them half and half, both drugs given sub-Q. Only 25% of the time did the surgeons comply with the protocol and actually give the drug before the operation. And then they had a venography done on day number 11. What they found was that pentasaccharide was significantly better than low molecular weight heparin. And in terms of bleeding, there was more minor bleeding with the pentasaccharide, but not more major bleeding. When we go to the knee patients, enoxaparin BID, probably more appropriate dosing for this. The last one I believe was 40 milligrams once a day. Versus pentasaccharide, both given subcutaneously postoperatively. They just gave up. They knew the surgeons wouldn't cooperate, so they just rewrote the protocol. And in this case, again, the pentasaccharide was more effective, and it also resulted in more return trips to the operating room, more need for blood transfusion, and death due to bleeding. I don't know what I just did. There we go. The bottom line with the pharmacologic prophylaxis is you really don't have a free lunch. You're having to sit here and endure this. The fewer DVTs and PEs means you're more likely to bleed. There's a whole host of new things on the scene. Melagatran is one that was going to be the great replacement for warfarin. This is a study that was funded by AstraZeneca looking at knee operations. It turns out that they were able to demonstrate improvement. It turns out also that they were, although not in the funded study, they didn't demonstrate an increase in bleeding. In the FDA's studies and the assessments, the bleeding was so extreme that it's now no longer FDA approved. So I had to check the box, am I talking about something that's not FDA approved? Yes, that is a drug that you can no longer get. You can still get it in Europe, but you can't get it here because it increases the rate of bleeding to death. So when you look at the p-values, don't forget to read deeper into the article. And then it gets into just really alphabet soup of all the different drugs that are out there. Most of these are really not pertinent for inpatient, critically ill patients. These are all direct thrombin inhibitors. Again, the last one has been pulled. I think it'll be a matter of time before we start seeing others of these being pulled. All of the surgeons have horror stories of Pradaxa. Argatroban was really the first one on the scene, but Pradaxa is the most prevalent in our population, and people just bleeding to death from their Pradaxa while we're trying to save their life. Platelet inhibitors, obviously one of the first ones on the scene, or the first one, is aspirin, which is a cyclooxygenase inhibitor, but there's a bunch of other different ones that use different methods. These tend to be used in arterial thrombosis because the platelet is really more of a player when there's high shear forces, whereas the clotting factors are the bigger players when you're in a low flow velocity state. And it gets worse. So there's your Plavix. The challenge with Plavix, it's only got an 8-hour half-life, but during that half-life, if you give any more platelets, it will inactivate them. So that's the problem with Plavix. Okay. Just a couple quick things about the other two methods. So what about the squeezers? So this is a study that was looking at thigh high versus the foot pump. And I don't know if any of y'all have ever seen the foot pump. It's probably so far gone now that it's, most of you haven't even seen one. But the idea was that by flexing the foot and causing the calf muscles to flex, that would basically have the same effect as the sequential compression device stockings. Turns out when they were compared head-to-head, and again, these are the SCDs that come all the way up to the thigh, and the med students have never seen those. The groups were pretty well matched. Actually, if anything, the SCD group was worse, and what they found was that the thigh-high SCDs were better than the foot pump. There's a pearl buried in this pony dung, and that is that the thigh highs actually do work better than placebo, unless we think the foot pump is causing clots. So thigh high sequential compression device stockings do work. Here's knee operations, high-risk patients. All of them received low molecular weight heparin, randomized to thigh high or calf high, DVT diagnosed by duplex. This was a very specific, expensive calf sequential compression device that had a roller system and actually increased femoral vein flow velocities significantly. And what they found was that the thigh high was better. So I think I'll just pass through this one. Bottom line is that why are we using calf high compression device if they don't work? Well, part of the reason is because the FDA, if you have a device, it's much, much easier to get it approved unless it's implantable and there's some, there's some other issues. But for an external device like this, the regulatory portion is very minimal. So what happened was there's a whole raft of studies that talk about how much better the compliance is with calf-high squeezers than with thigh-high. Okay? And you go through these things, and basically this one just says we tried SCD with and without foot pump, the thigh-high, and the foot pump didn't help at all. This one says, gee, if you use the calf-high, you get increased compliance. And there's got to be 10,000 nursing articles out there. I'm not throwing stones at nurses, but they're the ones that have to put the things back on the patient when they kick them off, saying how much better the compliance is with calf highs. The problem is they don't work. And I bet you the compliance with squirting heparin out the window would be, for the patients, it'd be 100%. You just go squirt it out the window every day. It still doesn't work. It doesn't get to the point. So the thigh-high is something that does work. It's probably better than nothing. It's not as good as pharmacologic prophylaxis. The calf-high SCDs do an effective job of treating the lawyers, because then we can say we did something when the patient dies of a pulmonary embolism, even though, nudge, nudge, wink, wink, it doesn't work. We all know it doesn't work. If you read the literature, it's very clear and unequivocal that it does not work, but don't tell the lawyers. The foot pump doesn't work, and the lawyers know it doesn't work. So don't use that. What about filters? So last part of this component, so we've talked about pharmacologic, we've talked about the pneumatic devices, and now we're talking about mechanical, blocking the clot from getting up to the cava. Dr. Greenfield used to work a summer job in the oil fields, and they had come up with a device to keep the whatever it is that comes up from the bottom of the well when you get a gusher. It turns out it's not all the black gold that Jed Clampett got. There's some other stuff that comes up with it, sludge that tends to plug up the works, and so they put a filter in there to keep that from gumming up the refinery works. And Laser said, wow, if they can do that there, maybe we can do that in medicine. And the Greenfield filter was born. Do they work? Should you put one in and take it out? And who should get them? First of all, safety. This is debatable. One of the most important points I want you to see on this is if you put a filter in, it doesn't mean you are protected, that's it. You're not going to get a PE. It also doesn't mean that you're not going to die from a PE. You can have a caval filter, I don't care what brand it is, and they all say, oh, but that's not our brand. It doesn't matter. You can have a caval filter put in and still die of a pulmonary embolism. Go back, rewind to the painful part that I was talking about, the basic science aspect of it's not a mechanical problem, it's an inflammatory problem. And so if it's a fresh clot, it hits the filter, it fragments and all goes up to the lungs out into the periphery, it's really done nothing to help you. The caval filter prevents a mechanical problem from happening. This is another study looking at IVC filters for caval thrombosis, which was one of the real dings on the earlier filters. The newer ones have gotten better, but I love the way that they published it because they said they had 67% IVC patency at 9 years. That also means that a third of the cavas were clotted at 9 years, so it's all how you spin the data. Another safety study from Michigan, from Laser himself. Again, recognize you put a caval filter in, there is no guarantee that you're not going to get a PE and that you're not going to get a PE that you're going to die from. He had about a 3% with his particular type of filter, and they're all different. This one actually is from my former institution that we published, and sometimes you don't really need statistical analysis. and you don't really even need to read past the abstract or even the whole abstract. Accidental intra-aortic placement of a greenfield filter. That's all you need to know. That's not a good idea. It's bad. It wound up going into the heart, and we had to extract it from the heart. So you don't need a p-value. You know you don't want to have that. Patient complained of chest pain, and here's just to prove, yeah, that I'm not spinning you guys yarn. This is the cable filter, nicely lodged over there in the heart. So what about efficacy? We looked at 3,600 Californians. Now that may bias the study right there because the land of fruits and nuts, but we looked at 3,600 Homo sapiens that lived in California. We age, injury, illness, gender matched them to 64,000 control patients and looked at the filter placement and their risk of subsequently developing a pulmonary embolism. And this is before the removable filters. And what we found was there was no difference in the rate of subsequent pulmonary embolism between the two groups, and there was an increased rate of admission for deep venous thrombosis, specifically in the group that got the filter. So long term, we know that you're going to wind up with an increased risk of getting DVTs from filters. The only study that really, and we'll just move through some of these, this is another one of mine, that basically what I found was that in the group that got the filters, we had a higher rate of pulmonary embolism than in the group that didn't. How did I get there? 28,000 trauma patients, 248 filters. We were putting them in like they were water. We thought they were great. It was going to prevent us from having to worry about pulmonary embolisms. We had 112 PEs. We looked at the time when we were not using them and when we were. We compared the two, low use, high use. The low use period bookend the high use period. So there was a year before and a year after, and then the 2 years in between were high use. During the low use period, that helped us to avoid the issue of, if you're using a historical control, which this technically is, even though it's historical in advance and retrospective, you run into very specific problems with the advancement of technology, and the later patients do better because we get smarter in theory. Anyway, low use, we put in less filters than we did during the high use period. That's kind of intuitive. And that number is right there. And the pulmonary embolism rate during the high use period was actually higher than during the period when we were putting fewer cable filters in. I'm not saying that filters cause PEs, but I am saying that they certainly are not a fail-safe by any means. They are not a fail-safe. This is, I think, the best study in the literature. It's been published multiple times over a number of different years. The initial study was published in the New England Journal of Medicine. 200 patients got a filter, 200 patients did not. They were randomized. They all had proximal deep venous thrombosis. They were followed for recurrent deep venous thrombosis, pulmonary embolism, and death. What they found initially at 12 days was there were 2 PEs in the filter group. There were 5 PEs in the no filter group based on clinical assessment. But if you added the routine VQ scanning that they did to them, everybody got a VQ scan prior to discharge. It didn't increase the number of filters in, of PEs in the filter group, but in the no filter group, it managed to push them up to a p-value less than 0.05 and the New England Journal of Medicine, so that's why the 9's in parentheses. In terms of bleeding, no difference. In terms of death, no difference. They went on to follow this cohort of patients for 2 years. And at 2 years, what they found was the significance in the rate of PE, or the prevalence of PE in the 2 populations. Now it's 6 in the group that had the filter, 12 in the group that didn't. That's now no longer statistically significant, The deep venous thromboses, as you would have guessed from our California database interrogation, were more in the filter group. Bleeding, no different. Death, no difference. Go out 8 years. Now this is, and I had an interesting discussion with somebody from the IRB. This actually is a retrospective analysis of a prospective study. You really cannot call it a prospective study, but because they had not had this in their initial protocol to do an analysis at 8 years. But they did, and that's good. I think that's worthwhile looking at it. So here, the filter group, 9 pulmonary embolisms, no filter group, 24, statistically significant. Deep venous thrombosis, more in the filter group. Phlebitis was present. Death, not significantly different. So it didn't alter mortality, but in the long run, at 8 years, it seemed to show some improvement in terms of the number of pulmonary embolisms. So do they have a role? Probably. So they increase the risk of deep venous thrombosis. They seem to decrease the risk of pulmonary embolism, and they probably don't have any effect on survival. Their conclusions was, although their use may be beneficial in high-risk patients, the systematic use in the general population with thromboembolism is not recommended. So there was, for a while, a very strong contingent of trauma groups that were putting them in prophylactically, and that's probably not a wise move. Removable filters, I'll just kind of cut to the chase, which is, this is, again, going back to my data of pulmonary embolisms and when they occur. And this line is asymptotic. That's not a bad word. You can say it in front of your mom. But it means that it's never going to go back down to 0. So when do you take that filter out? And if you put it in through the groin, which you're not supposed to, but if you really poll the groups, the majority of the groups put them in through the groin. You're supposed to put them in through the neck. If you put it in through the groin, then you're going to have a clot in the groin, and then that's going to set you up for another PE. And then when you take it out, you've damaged the vein. So that's another risk factor. So the conundrum of when do you take them out, I don't think has been settled. And this is more pharmacologic of how long do you treat people. Let's just cut to the bottom line. So do the filters do damage? Yes. Do they have a benefit? Probably. Should you use them? Rarely. And then my ultimate, we'll go to conclusions. So if you're doing a high-risk operation, my recommendation is either use, actually let's go back, moderate risk operation. You can do low-dose heparin started the day before surgery if the patient is not a trauma patient. You can use adjusting dose heparin, which is you give it IV in just enough quantity to raise the PTT to 2 to 5 seconds above normal. That's been shown to be superior to this, but I didn't want to show you those studies because the LD50 of that talk gets to be too high. And low molecular weight heparin is another option. This one, why not? Doesn't hurt, might help. If it's thigh high, if it's calf high, you might as well put the money in a fund to buy a TV for the med students. What about high-risk operations? At this point, I think that the sub-Q heparin's probably no longer beneficial. You should either go with adjusting dose, that is enough to raise the PTT by 2 to 5 seconds so you can counteract that you already know the study's been done, that if you have major trauma or trauma related to surgery, your antithrombin stores are going to be depleted. You know that. It's been done. So you can counter that by giving more heparin, and that counteracts that depletion in antithrombin. Give them low molecular weight heparin, pentasaccharide, but remember with that you're going to have more bleeding. SCD, They got to be thigh high, and alone they're not going to be adequate. For trauma, thigh high SCD, if you can use them, they certainly might help. They don't hurt, and why not? And my conclusion is either use adjusting dose heparin, where you're adjusting the heparin to counteract the fact that you know the antithrombin's going down, and low molecular weight heparin, that one's been shown to be effective in decreasing DVTs, but don't use 5,000, 7,500, 10,000 sub-Q TID. It's completely ineffective. It doesn't work, and the Cat-5 squeezers don't work. What if you can't anticoagulate them? The neurosurgery says, no, 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 can't do it, you may not. Well, use SCDs, and if the patient has a bad pelvic fracture and they're my age, probably put a filter in. Stuff to think about. This was the last one, and I particularly like this study because it's in the New England Journal of Medicine, and basically what it says is if you have a system that tells people to do something, they do it. That's it. That's all it says. Electronic alerts to prevent PEs in hospitalized patients. When we reminded them, they actually did the prophylaxis. If we didn't, they didn't. That's not really earth-shattering, but the New England Journal liked it, so they made a point of it. That's it, and I would be happy to answer any questions that you might have if you're still alive or awake. Yeah,
now, one of those things that always bothered me about filter experiments is we have the low use and the high use. Yours, but you have similar other studies. What's happening to the patients in the low use? I mean, are they totally not getting any other prophylaxis, or both of those groups getting prophylaxis?
Yeah, at least in our study, the use of heparin was unchanged between the two groups. There was no difference in our practice. And where we were, the pharmacy was much, and I can't put enough adverbs in front of it, more restrictive than it is here. We couldn't get enoxaparin. The only thing we could get was unfractionated heparin. So we used the dose adjusting method with unfractionated heparin for both groups. And that has been shown to be at least equal to, if not superior to, blind use of unfractionated heparin. An interesting question for the group is, can you monitor, so with the unfractionated heparin you can check the PTT, what about Lovenox? Can you monitor the Lovenox effect? How many people think you can monitor Lovenox effect? And if you don't answer, I'll just ask you what you think. So you got to vote. How many people think you can't monitor its effect? Nobody's voting. The answer is, and it's sad because the problem is a lot of clinicians don't get in depth enough with the basic science. You cannot. If you send it to the lab and you ask for an anti-10A assay, what they do is they say, okay, we're going to look and see how long it takes the blood to clot with this low molecular weight heparin in there. We know what the normal standard is, so we can compare it to that. But they don't want to wait all day, right? So what do? They spike the sample with antithrombin so that all the specimens have the same level of antithrombin. So what you're getting is, when you do an anti-10A assay, you're getting the amount of low molecular weight heparin in the body, not its activity, because its activity is dependent upon the antithrombin in the body. And they spike the sample, and all the major assays do that, and 99.9% of physicians don't know that, so you can't measure its activity. We do not have a test unless you go to your lab and you're really good in with your lab. In my research lab, we did non-spike anti-10A levels, and it followed the same curve as the PTT in unfractionated heparin. But just one of those things that I think is worth knowing. Yeah, Lloyd?
I guess, what time period or how long after the trauma should you start based on
As soon as you possibly can. So I would say that if the patient doesn't have an active bleeding diathesis, I'd start it immediately. At the very least, I would start it within the first 24 hours. When do I not want to start it? The thing that scares me, and there are not very many things that scare me away from giving heparin just enough to bump the PTT by 2 seconds, but an intraparenchymal bleed in the brain, that one scares me, because that one can blossom and turn into really bad problems. An epidural that's been drained, that one's fine. Subarachnoid hemorrhage, I don't worry about that, that's fine. A patient who's actively exsanguinating, okay. If you're doing the massive transfusion protocol, probably not a good idea to try to go out and find some, you know, Pradaxa or heparin or something else like that. Yes, sir.
In keeping with your idea that it's an inflammatory mechanism that's so dangerous in pulmonary emboli, would you recommend a large dose of Solu-Medrol intravenously as soon as you suspect the diagnosis of PE?
So it's a very insightful question. If it is an inflammatory process, why not attack the inflammatory system? And as you may remember, the people that are more than 10 years into this, there was a big push to use activated protein C, which is essentially a brother or sister moiety to antithrombin. It's an endogenous antithrombotic, and they marketed it as an anti-inflammatory in its improvement, decreased death due to sepsis. The answer is, I don't know the answer. But I do think that there is no difference between the clotting cascade and the inflammatory system. They are one completely integrated, inseparable entity, and to try to separate them and treat them separately is foolishness. And so I think at some point we're going to come up with, the Solu-Medrol has a lot of downsides in terms of wound healing, bleeding, increased infections and whatnot, but something I think is the right answer, and I think you're spot on. I think yes, something. Antithrombin actually is an anti-inflammatory. Protein C is an anti-inflammatory. So, and whatnot. So this was trauma-specific CME, so if you need trauma-specific CMEs for our next ACS site visit, make sure you list it. Thank you so much for your attention. I really appreciate your time.